Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I am the chair-elect of BTOG. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers. It is important to say that sponsors of BTOG do not have any role whatsoever in the planning, delivery, content of anything discussed today.
Hello and welcome to another BTOG podcast. I'm delighted this week to be taking on the thorny subject of mesothelioma and surgery, and this is a very apposite time to be doing that, and I'll explain why that is in a minute. I'm going to be joined by two guests. We're actually recording this slightly separately, and the first guest is Professor Eric Lim, who is a professor, or the professor, of thoracic surgery at the Royal Brompton Hospital in London. And I will also be speaking to David Waller, who is a consultant thoracic surgeon at the Barts Thoracic Centre. And I've chosen Eric and David in particular because of their interest and their involvement in an important trial called the MARS-2 trial. And the MARS-2 trial, as we will hear in a second, is a study of the role of surgery in mesothelioma. So first of all, we're going to talk to Eric Lim, and I'm going to ask Eric to describe a little bit about MARS-2, what it was, and so on. So Eric, welcome to this BTOG podcast. Thank you very much for joining us.
Thank you very much, Tom. MARS-2 is a trial about extended pleurectomy decortication and chemotherapy versus chemotherapy alone for patients with resectable early-stage mesothelioma. It's a big deal because every single guideline in the world recommends surgery as an option for patients with resectable disease, and many drugs are licensed in the unresectable setting.
Yeah.
MARS-2 is designed and conducted by the UK Mesothelioma research investigators to compare the clinical and cost effectiveness of extended pleurectomy decortication and chemotherapy versus chemotherapy alone.
So I'm going to stop you briefly there and ask you one thing, just because when I started out doing this, I wasn't really sure. Tell me what an extended pleurectomy decortication is for someone who knows nothing about surgery like me.
Right. So there are three principal operations for mesothelioma. I call them big, medium, and small.
Right.
The big operation is called extrapleural pneumonectomy, where you remove all the disease in the lining of the chest, you remove the lung, the lining of the heart, and the diaphragm. That was evaluated in MARS, and we found a 90% increase in the risk of death. There's a very small operation called partial pleurectomy, where you remove part of the diseased part of the lining of the lung or the chest wall. That's called partial pleurectomy, and that was evaluated in mesovats, showing no survival improvement and possibly better outcomes with drainage and talc.
Okay, so that's big and small. So big and small are not done routinely in clinical practice. Is that a fair thing to say?
Correct. So the medium operation is extended pleurectomy decortication, and that involves removal, the lining of the chest, the diseased lining of the chest, the diseased lining of the lung, plus minus the lining of the heart and the lining of the diaphragm, if it is involved, to achieve macroscopic, which is all that the eye can see, disease removal in mesothelioma.
Okay, that's really clear. Sorry, and thank you very much. And then you're just telling me about the MARS-2 design. Thank you.
Yeah. So we recruited patients with tissue-confirmed mesothelioma, confined to one hemithorax and deemed resectable. Patients underwent 2 cycles of cisplatin and pemetrexed chemotherapy, and a repeat PT, and if still resectable, were randomized to surgery and chemo or chemo alone. The study was conducted between 2015 to 2021, where we randomized 335 patients, 169 to surgery, and 166 to chemotherapy alone.
And that's a huge number. So just to put into perspective for our audience, to achieve that and those numbers in a disease like mesothelioma and trying to do surgery is an astonishing achievement. And in your presentation at World Lung, so I should say to the audience, this was presented at the World Lung Conference in Singapore in September 2023. And I'm not just saying this because Eric's in front of me, but it was the most fantastic presentation. And if you can listen to it or watch it, I'd really recommend it because it's very captivating and it really puts energy into the subject. And Eric really clearly describes what an achievement it was to get that many patients into a study like this as a national effort across multiple centres?
Thank you, Tom. The primary outcome, much to everyone's surprise, revealed that surgery, which is the last operation now currently offered worldwide for mesothelioma, was associated with an increased risk of death compared to chemotherapy alone. In our latest manuscript, we describe the risk of death as an average of 1.9 months shortening of the survival at an average time frame of 24 months.
Gosh.
In addition, patients who were randomized to surgery had 3.6-fold higher serious complications and poorer quality of life, especially when estimated using EQ5D that weighs in death into account. We can see considerably worse utility for patients who receive surgery.
Wow. So that's very stark. Now, we should say that you don't have a dog in the fight because you don't do mesothelioma surgery. So I remember you saying to me once, you're an equipoise about this. If it works, you're delighted, and if it doesn't work, it doesn't work. Your take on that mortality and that quality of life data, what's your view as an impartial surgeon?
I think I was selected to be the chief investigator for MAS2 because I don't offer mesothelioma surgery. And of course, as a surgeon, I'll be rooting for the operation to succeed. And if the operation did not succeed, then I would be rooting for the patients to ensure that we're doing the right thing.
Yeah.
So even for me, the results came quite as a shock because myself and everybody around the world expected the results to be positive in favor of surgery.
Yeah.
But the results, many people think the MAS2 results are negative. The MAS2 results were not negative. The MAS2 results were positive, but in the opposite way, which means a statistically significant increase in the risk of death.
Yeah, that's really helpful, very clear. Tell me a little bit about how you ran the study and the number of centres and who was doing the surgery. Was this anyone can have a go, or was this in selected centres that actually knew what they were doing when it came to mesothelioma surgery?
The concept of surgical quality assurance has always been in the forefront of our minds, right from the word go, right from the inception of the study design. And in this study design, we selected 5 sites to take part, 5 surgical sites, 4 recognized high-volume centers of excellence in mesothelioma surgery. And that was Leicester, it was Guy's Hospital, it was Barts, it was Sheffield. In addition, as part of the trial design and intentionally, we chose one non-high volume center, and that was Glasgow. Now, each of the sites had surgical quality assurance in that there were 3 principal surgeons that started out the study: David Waller, Apo Nakas, and John Edwards, of the 3 highest volume surgeons in the country.
Yeah.
We made all 3 of them watch each other operate and make sure that they standardize their operation according to the IASLC definition for surgical resection for extended parenchymal decortication.
Okay.
Then, for each of the 3 expert surgeons, any new surgeon that comes into the trial, their first operation will observed by the 3 expert surgeons. In addition, we issued a surgical manual to ensure that the surgeons were undertaking the operations in a standardized manner. And to check for fidelity at operation 5 to 10, a random operation, we got one of the first wave surgeons to come back and check. So the quality assurance for the actual conduct of the operation was conducted to the highest possible degree and also supervised by a panel of international surgical experts. With regards to surgical volume, the current accepted definition of high volume is more than 5 cases a year. And in the 4 expert centers, during the conduct of MAS2, the volume was 8.6, 14.3, 27.6, and 36.5 cases per year.
So that's significantly above what would be seen as high volume.
Correct.
So even your quieter centre was above what would be seen as the standard for busy.
Yeah, so the one non-expert center had a volume of 3.4 cases per year by design.
Right.
But what was important to understand that even in the quieter centers, all the surgical sites during the conduct of MAS2 had a significant proportion of patients randomized to medical treatment. In addition, there were 2 years of pandemic, so the surgical volume was greatly reduced during the time where they participated in MAS2, and despite that, the highest volume centers in the UK in that period had volumes comparable or higher to the most active sites in North America.
Got you. That's really helpful. So who decided whether someone was resectable? So if I was sitting in my MDT, a patient came through with mesothelioma and they've got good performance status, and I thought this might be someone from MAS2, was that decided in the local MDT or was that decided in the MAS2 center MDT?
It was decided in the MAS2 center MDT in
Okay.
2 rounds. The first round is initial evaluation where the patient is staged, and then they would have 2 cycles of chemotherapy, and then the MDT would restage them with CT, and then redecide with the operating surgeon or representing the site present to determine resectability.
Yeah. Okay. That's very helpful. You talked about the increase in mortality. You talked about the reduction in quality of life as determined by the EQ5D and other metrics. Any other key outputs from the study that we should talk about?
Yeah, the complication rates, as you expect, would be higher with the patients who are randomized to surgery. The other key outcomes for MAS2 principally centered on progression-free survival, which is approximately the same. And people are always wondering, why is it that the disease-free survival is approximately the same? And the answer, because of the higher surgical death rates. So in order to have progression or death, the numbers then equalize because of the higher deaths in the surgical arm.
Yeah, got you. So that was the main outcome of the study. What is your view of how that leaves surgery in mesothelioma? Does that mean we should also be stopping it? Does that mean the study doesn't really answer the question, we should continue it? Does that mean there are still unanswered questions?
Well, that's a great question, Tom. I think that we need to explore the whole concept of resectability for mesothelioma in all the 3 randomized trials conducted to date. They have uniformly shown worse survival with surgery for mesothelioma. With regards to surgical cytoreduction, MAS showed a 90% increase in the risk of death, and MAS2
just remind people, MAS was the extra pulmonary pneumonectomy, massive surgery. That was
extrapleural
published
pneumonectomy.
10 years ago, roughly?
Correct. And MAS2 in the early phase showed a 28% increase in the risk of death. And so all randomized trials for cytoreductive surgery to date have statistically significantly increased death after surgery. One big barrier to progress is the community, not just surgeons, the entire mesothelioma community hanging on to the concept of resectable. And that's important because it's not just a word. Drugs are being licensed on the basis of resectability. And so dual immunotherapy, according to Checkmate 743, would be licensed on the basis of unresectable disease. And if we don't consider giving up the concept of resectable, then all these patients are not eligible for effective systemic treatments. And I think that's going to be a very important issue going forward.
That's very helpful. So what we're going to do now, we're now going to cut across to a discussion I had a little bit earlier with David Waller, who, as I'll go on to say, is a thoracic surgeon at Barts Thoracic Centre. And then we're going to rejoin my discussion with Eric Lim in a few minutes to see his thoughts on David's points. So, David, welcome to this BTOG podcast.
Thanks very much, Tom. Nice to participate.
Thank you. So you know the results of the MAS2 trial. You know that when in the hall in Singapore, we heard about the trial showing an increase in the risk of death, increased risk of serious complications, reduced quality of life, and the cost of surgery. And a lot of people would say, well, that's a that's a slam dunk. That's the end of surgery. We should not be thinking about it again. I think it's fair to say you don't share that point of view. So I wonder if you could give me a brief summary of where you feel the trial fell short and why there's still questions, and then perhaps we can go through a couple of those in greater detail.
Yeah, thanks. Well, first of all, to say I was the leading recruiter to the trial. I started when I was a consultant in Leicester, and then obviously continued at Barts. And Barts were actually the leading recruiters of surgery to the trial. So I obviously have the biggest experience of the sort of patient that went into the trial. So I'm going to give you a soundbite that we used at the meeting this week. We just had a debate, Eric and I. And basically what I would crystallize the message of Mars 2 was the critique would be too many, too much, too late.
Okay.
And the implications that it means all surgery should stop for mesothelioma is, I would say, throwing the baby out with the bathwater. Because I think beneath the data, there's still a question about whether surgery has a role in those with the best prognosis. And that was the criticism.
And so that's your focus, is on those with the best prognosis, not on perhaps the majority of patients.
Problem with Mars 2 was we sacrificed the rigor of selection in order to achieve recruitment. And we sort of knew in advance that was what we were doing.
Okay.
Because we got our fingers burnt in Mars 1, where we were quite prescriptive about the recruitment, about the selection rather, and the recruitment suffered. And therefore we couldn't do a phase 3 in Mars 1 because we simply weren't recruiting fast enough. In Mars 2, we opened up the selection to patients with non-epithelioid disease. That's the worst type of mesothelioma. And we weren't too prescriptive about the staging. And the only brief that the surgeons had was that they had to be able to take out all of the visible disease. And that included lymph node metastases and included locally advanced disease. So that's not quite what the international consensus is about the indication for surgery, where the Americans, and we had an American surgeon this week from the Mayo, saying that their indication for selection for surgery would be stage 1 or stage 2 epithelioid mesothelioma.
Okay.
And I'll come on to explain we've done some post hoc analysis, and I have data from 3 of the 4 trial centers, and that group actually makes up a very small minority of those patients in Mars 2.
So just to stop you there for 1 second. So we feel the sarcomatoid patients and non-epithelioids shouldn't have been included. And your rationale behind that is, unfortunately, their prognosis is much worse. These are not people who should be having surgery. That's a fairly non-contentious point, isn't it?
So that's the too many. So
that's
the too many was that we included those with non-epithelioid, those with known worse prognosis, whereas in Mars 1, we limited it to epithelioid.
And you mentioned the staging. You mentioned, for example, PET wasn't mandated and EBUS wasn't mandated. That wouldn't be seen as standard of care in routine practice at the moment, but you feel this would have been a useful thing and an important thing in the trial setting. Is that correct?
Yes, that would be the too late. The too late means that we operated on the majority of patients were in stage 3, and so they had lymph node metastases that we hadn't excluded preoperatively by either PET or invasive staging. And also they had locally advanced disease going into the diaphragm, again, which we didn't exclude by MRI scans, for example, preoperatively. So the criticism from the international reviewers was that we were operating on too late a stage of disease and later than would be recommended in the international consensus and is currently practiced in the large North American centers, for example.
Okay. So that's the too late. And your third one was?
So then we did too much. We took out too much because we were operating on more advanced disease, and our brief, quite simply, for the surgeons, was to take out all of the visible disease, which in 80% of the patients required resection of the diaphragm and pericardium. Now, it's a big achievement that our operative mortality was less than 4%, and that's in line with international consensus. So we can't be criticized of being poor quality surgeons.
No.
Unfortunately, and the hospital stay was around 12 to 14 days, so patients didn't die in hospital. But what we did find was that I think it was about 18% of the patients in the surgery group died from the operation or the indirect effect of the operation with no disease progression. And that's really the big difference in the survival curves, where they run virtually parallel until they cross over at about 4 years. But in the initial, let's say 90 days to 3 to 4 months, there was an excessive mortality in the surgery group, and the causes of death were largely cardiorespiratory. So these were fairly elderly patients, median age around 70, who had an extensive operation. Although we preserved the lung, we took away the diaphragm in 80% of them, and that did leave them extremely compromised, more than we expected, I think.
Yeah. So that's the too much. And so there were a couple of other criticisms of the study which had been mentioned around the time. One was, there are only, I think it was 5 sites in total. Could that lead to bias? What's your take on that? Or actually, do you think it's right to have a smaller number of centres so that you can ensure expertise in those centres?
Yes, we were very conscious of the criticisms in Mars 1 about quality control. And so we made very strong efforts to ensure quality control. We had cross-validation of surgeons. And yes, I don't think there was any bias because we all were doing the same operation. It was just that was probably too big an operation in retrospect. And it was basically because we were trying to resect a more advanced stage of disease than we probably should have done.
Other things I've noticed was there was a bit of imbalance in the arms, more, for example, pulmonary extension in the surgical arm. Do you think that was significant, or given what you've talked about, the extent of disease, was that perhaps?
Well, we didn't do formal lung resections. We may have done wedge resections. I don't think physiologically that was too big a problem. The big problem was taking somebody's diaphragm out and the effects that has on the respiratory function.
And then some other people mentioned, particularly the oncologists, as you might imagine, noticed there was less chemo, adjuvant chemo in the surgical arms, perhaps reflecting the impact of the surgery. Do you think that's relevant? Does that mean it's not a true comparison of surgery because actually there's a variation in chemo? Or do you think the chemo is a small print here compared to the surgery?
Well, no, either you believe that the survival in the non-surgery arm was down to the effect of chemotherapy, and therefore if you believe that chemotherapy has an effect and that the survival in the no surgery group was not just natural history, but then presumably if one group gets more of that agent than the other, then that would affect the outcome. Now, Eric's done some form of modeling, but I don't think that's been validated to try and counteract it. It seems counterintuitive. But if you believe in the effect of chemotherapy, and that's how you explain the survival of one arm of the trial, if one arm got more of that than the other, then one would think that would affect the outcome. However, and as Eric quite rightly said, it was an intention to treat. So if you attribute the difference in chemotherapy to the operation, then that's obviously a bad thing about the operation. And I do that. There was we looked at the reasons, and we have some data on some of the reasons why patients didn't complete chemotherapy. And let's be honest, 40% of the surgery arm only had the induction therapy. So effectively, in 40% of the surgery arm, it was a trial of surgery alone against chemotherapy. And we know that wasn't the intent of the trial.
Yeah.
And so if we had been able to do on earlier stage disease, a less aggressive operation, one would have hoped that more of patients could complete systemic therapy. As I say, some of it was down to patient factors. There was an element of reluctance on the behalf of the oncologists to give adjuvant therapy. Now, some of that may have been driven by the patient. There was a small proportion of patients that had received induction, they all received induction chemotherapy, but a small proportion had progressed on chemotherapy, and therefore there was no indication for them to have post-operative chemotherapy. It hadn't worked pre-op. Whether they should actually have ever been in the trial is another moot point, and probably they shouldn't, because we know that's in itself a bad prognosis. And then there was the fact that twice as many people in the no surgery arm received immunotherapy.
Yeah.
Now, if you believe that the results of Checkmate 743 are attributable to immunotherapy, and it's not just the fact that chemotherapy doesn't work at all, then again, if twice as many patients in the no surgery arm received immunotherapy, one would again think that was a confounding factor. But again, and it's a way of explaining the results, but Eric, again, quite rightly would point to the fact that they didn't get immunotherapy because of the operation.
Yeah, yeah.
So I think it all comes back, Tom, to the fact that, yes, there was an imbalance in the systemic therapy, which inevitably will affect survival, but the reason there was an imbalance must come back to the extent of surgery.
Indeed, as you said. So those are clear issues that you have with the study. How do we move on from this? So like every study, there are limitations, there are problems in design in the results. Do you feel it is still appropriate to do surgery for a properly staged, early stage, non-sarcomatoid mesothelioma? And if so, could that be in routine clinical practice? Or given the results of MARS-2, is that something where we need to show that is safe and appropriate in a trial setting?
Yes and yes. I think what we must guard against, and what happened after the Singapore presentation, was a gut response that surgery is finished. And that, unfortunately, was the take-home message. And that has been very difficult to counteract. There was a large enthusiasm, obviously, from oncologists who specialize in mesothelioma to say, there's no role for surgery. Everybody should have immunotherapy. Mm-hmm. And that's been very difficult, because I've been told that some MDTs have said, that's it, we're not even considering surgery for anybody now. And that was on the basis only of one abstract, without it ever being peer-reviewed or published. And I hope the publication, which hopefully will come out later this year, will include a caveat on the lines of what I've just been discussing. So yes, I think, well, put it this way, in North America and in Asia, patients with stage 1 and 2 epithelioid mesothelioma are still being offered surgery. It would be a shame if, as it used to be, British patients would have to pay to go to America to get that sort of surgery, which they did. I remember they used to pay to go to Boston to get extrapleural pneumonectomy. So yes, I think, and the way forward has to be to test that against what would be best standard of care in the non-surgery, which now would be immunotherapy, of course. So that would be the control arm. And I think that's where we should go.
And that would be what? That would be given the difficulty in recruiting to this, given the fact this would now be a much smaller patient group, a much more select. This have to be a multinational, international study, correct?
When we looked at the data I have access to, it worked out that about 1 in 5 of the patients we put into MARS-2 from Barts would now be offered operation. So they would be the ones we would consider for MARS-3. Now, if you assume a relatively similar power of the study, you would need either 5 times as long to do the study or 5 times as many centers. Now, that's obviously going to mean a multinational trial. And I think once Mars 2 is published, there will be an international, well, there's already a comeback in America. The oncologists there have suggested there's no role for surgery. So it may not be possible for the American surgeons to carry on without trial evidence to back it up. So, and there is a move in the international mesothelioma community to commence on Mars 3 as an international trial.
And the appetite to do that as well. I mean, people presumably.
Well, it's driven, Tom, by the survival data, which will inform the 9th TNM revision, which shows that, for example, in clinical stage 1 epithelioid mesothelioma, you've got a greater than 50% chance of being alive at 3 years. And even in stage 2, you've got a 40% chance of being alive at 3 years. So there's meaningful survival data after operation internationally. And I still think that a 50, 55-year-old patient who's otherwise in performance status 0 to 1 with stage 1 or 2 epithelioid mesothelioma should at least be given the opportunity to have surgery as part, which would be diaphragm sparing, lung sparing, thorectomy, because you can do that for early stage disease, so a less morbid operation.
And when that person comes to your clinic room and says, "I'd like to have that surgery," how do you couch that in terms of the Mars 2 data? Do you say, "Well, look, there's been a study, it has shown this"? Do you think a surgeon needs to explain that mortality data from the bigger stuff?
Well, I explain just as I've explained it to you, that the group represented by that patient represents 1/5 of the trial, and therefore it's difficult to extrapolate the results of the trial onto that specific group of patients. There was no, the subgroup analysis shows there was no difference in survival within Mars 2, but it's of course not powered to show a significant difference. And again, there was crossover in the later stages of follow-up. So yes, I think I would say, well, I have done, and I have operated on patients since Singapore, and I've said exactly that the results of the trial, and patients are well informed nowadays, and they have access to the internet postings of the trial. I've said that doesn't necessarily apply to you, but we do have survival data, international survival data on a couple of thousand patients that show that this is your survival from an operation as part of multimodality therapy. So they're the two factors I would explain to a patient, that Mars 2 doesn't necessarily apply to you. And there is still reason to believe you may have an extended survival by surgery. But I can't put you into a trial at the moment because I can't immediately start Mars 3. But we are actively seeking to do that. And of course, we're actively recording data of the patients that we operate on anyway, until we can actually start recruiting into the randomized trial.
That's really clear. Thank you. My last question is there an appetite, or is there a need or a question for Mars 4? In other words, beyond what you set out as Mars 3 as a potential trial, are there any other surgical questions to ask? Are there different techniques, are there different approaches which we will still want to know about in the future, assuming, let's say, that Mars 3 shows that surgery in early stage is still something we should be doing?
Not really, Tom. It's really like Goldilocks and the Three Bears. We've done too much with EPP. We did too little with Meso-VATS, which was just a video-assisted debulking procedure. So we did an R2 resection. And I think Mars 2, we erred towards the EPP end. And probably now, in fact, it was the removal of the diaphragm in Mars 1 that was morbid. The lung was probably non-functioning anyway in more advanced mesothelioma, and it was the additional effect of taking the diaphragm, which we know is a big physiological threat to the patients. And so in Mars 2, we overdid it, but there's still an element, and we now promote diaphragm-sparing thorectomy with lung-sparing thorectomy, and that's feasible, and that's what we do now. And we have published data since Mars 2 finished recruiting. In fact, of course, we were still not all patients were happy to go into MARS-2. And we have survival data showing a benefit in the same stage of patient by preserving the diaphragm. And in those patients, their 3-year survival was 57%, and that's published data from Barts. So we've evidence to show the patient that this is what might happen if you have the operation. We can give them informed consent. I can't tell them that it's necessarily better than not having surgery and just having immunotherapy. Immunotherapy, the problem, and one of the other spin-offs of the MARS-2 trial was the fact that NICE has recommended immunotherapy for unresectable mesothelioma.
Yeah.
And that's led on to the assumption from MARS-2 that all mesothelioma is unresectable. And that's what I have issue with.
Yeah.
I have no issue with Eric's interpretation of the data in terms of the randomization accounted for a lot of the deficiencies. But I do have a problem with the interpretation that says that therefore all stages of disease are unresectable.
Understood.
It would be the same as us doing a trial in lung cancer and operating on predominantly stage 3A disease or even 3B disease, throwing in some small cell lung cancer if it remained potentially resectable, and then finding that actually surgery versus systemic therapy had no difference. But then the conclusion would be there's no role for surgery in any stage of lung cancer. You can see, who can understand that would be unreasonable. And I feel in the same way, until we can actually conclusively do a stage-dependent trial, I don't think we can say all disease is unresectable.
Well, David, you've been really clear. Thank you so much for your calm and considered reflection. We, of course, look forward to seeing you headlining ASCO 3 and sorry,
Yes.
Mars 3 at
Mars 3,
ASCO
yeah.
in, well, I'm not sure when
it
it will
may
be.
not be me in person, Tom. I may have retired by then, but I certainly will help in its.
I think they'll drag you back from the golf course for that. But thank you so much for sharing your thoughts, and thank you very much for taking time to speak to us on this podcast.
Nice to talk to you, Tom, and thanks for the opportunity.
Thank you. So, Eric, we've heard about those challenges, I guess, from David Waller, and like all studies in the world, there are great points about MARS-2, and there are, of course, criticisms and valid flaws. I guess focusing on the main thrust of his argument about who was involved in the study, and the stage of the disease that was involved, and the pathological subtypes, the involvement of sarcomatoid, not just epithelioid. How would you reply to those challenges?
So let's take it one question at a time and start with non-epithelioid disease. Firstly, why would we operate on non-epithelioid disease? Because statements like ASCO in 2018 suggested that patients with histologically confirmed sarcomatoid should not be offered maximum cytoreduction, and that led to the so-called contraindication of surgery for non-epithelioid disease. It's of no coincidence that the Americans themselves absolutely contradicted themselves by operating on non-epithelioid disease. And studies by the Boston group, published in 2022 by Lapido, always goes back to the concept of highly selected patients with biphasic mesothelioma have good outcomes of surgery.
Right.
So there is a huge equipoise or unknown where some or most guidelines don't recommend surgery for non-epithelioid, and yet North American centers and other centers around the world saying that with surgical selection, you can get good outcomes. Now, you can't have it both ways. It's either you don't operate or you evaluate it in a randomized setting to determine whether or not that concept is valid. Now, if you take the concept of surgery for lung cancer in stage 1 and stage 3, if the operation works across the stages, you would expect a greater benefit in stage 3 because of the absolute difference will be bigger. And because it's never non-epithelial surgery for non-epithelial disease has never been evaluated in a randomized setting, we sought to undertake it as a world's first to determine whether or not, if you offer the same operation for 2 different cell types, does something happen that the actual operation works differently and causes harm instead of benefit? And mathematically, we call that an interaction effect. So we wanted, right from the outset, to assess or look for this evidence of an interaction effect. And so non-epithelioid disease was pre-specified as a criteria for study entry. It only consisted of 12% of participants, of which 3% were sarcomatoid and 8% were biphasic. The outcomes were carefully monitored by the Data Safety Monitoring Committee, and for the first time in the world, we demonstrated statistically significant interaction, which means to say that an operation done the same way for two types of disease had totally different outcomes.
Right.
But perhaps coming back to the crunch of the story is that even if you did not or excluded these 12% of participants with non-epithelioid disease, the risk of death for pure epithelioid alone was 12% higher anyway.
12%. Okay.
So that didn't, in fact, alter the results and of the study for the primary outcome.
And the comment about stage of disease and I guess operating on people with hindsight who had more disease, I guess, than we might see as being optimal for surgery, and that actually there is this subgroup of very early stage patients where this is the benefit's been drowned out by the rest. How do you see that argument?
When we design the study, the operation is defined as extended thoracic decortication. It doesn't really define as early, a little bit, somewhat, or a lot of disease. The definition is that all of it can be resectable. And in general, we achieved complete macroscopic clearance in 84%. And in that number is considered to be very good by surgeons across the world. And before the MAS2 results were revealed, I actually asked many expert surgeons, including many of the eminent North American surgeons on the trial steering committee, and everyone was very satisfied with it. So in that respect, I would say that the operation achieved what it sought to achieve in 84%. And because 16%, the disease was more extensive than anticipated, that's not uncommon in mesothelioma surgery. We, as a result of the reviewer's request, performed ad hoc further subgroup analysis looking at the ideal profile, which is T1 or 2, N0, M0, pure epithelioid only disease, and confirmed that survival still remained poorer with surgery in the subgroup. So by all means, question the results of MAS2, challenge it, but until people do so, we would regard the outcomes of MAS2 as the current best available evidence.
Yeah.
And in fact, I think because we have generated the current best available evidence, the paradigm should be turned the other way around. People should be asking themselves, if you do conduct surgery, then that should be done in an experimental setting. And I feel that it shouldn't be offered routinely, clinically. Having said that, there may be very, very few select patients with disease which are so small that patients and surgeons and MDTs would consider, undertaking resection, but that should be the exception rather than the rule.
So if one was to continue surgery in the early stage patients more routinely, you feel that should be in the setting of a clinical trial whilst one establishes the true benefit or not?
I think so. And also with the results of MAS2, I think there will be an onus to let patients know, you have early stage so-called resectable disease, but a clinical study showed that patients in this setting had a 28% higher risk of death. Would you like to participate in a clinical trial to evaluate and put your reasons here why you think, MAS2 results were not valid, and then evaluate patients going on in that manner when you offer surgery in the setting?
Yeah. That's really very clear. Thank you very much. And as I say to the audience, if you can listen to Eric's presentation at World Lung in 2023. It's a great show, and it's a great way of picking up research in the UK, which is something I don't think we necessarily do very much, and certainly not enough. So Eric, Lynn, thank you very much for joining us. Thank you also to David Waller for joining us, and thank you for our audience for joining us for another of these podcasts.
Thank you very much, Tom.
For more information on BTOG, including education events and how to become a member, you can visit us at www.btog.org.